Hello, everyone. Welcome to the second webinar from our Liver in the Balance series, hosted by the Office of Lifelong Learning and the Physician Learning Program at the U of A. So my name's Panita Tandon. For those of you who were here last week, you've met me already. I'm a professor of medicine and co-director of the Cirrhosis Care Clinic and transplant hepatologist at the U of A in Edmonton. And I'm also a medical director for the Office of Lifelong Learning and the Physician Learning Program. The Physician Learning Program and the Office of Lifelong Learning are committed to providing reliable updates and resources for clinicians, healthcare professionals, and everybody committed to providing the best care for patients. I'll just ask to flip to the land acknowledgement slide. So the University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Cree, Blackfoot, Stoney, Iroquois, and Ojibwe and Saulteaux lands that are now known as parts of Treaties 6, 7, and 8 and homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. And some quick housekeeping information before we get going with Dr. Ma. Please use the chat feature if you have a question about technical difficulties or L3 programs and services. If you have a question for the speaker, and I would encourage you to ask a lot of questions, please use the Q&A feature of the webinar. Please review what's already been asked and upvote those questions just in case we can't get to all of them. And a recording of the webinar will be sent by email to all of you who registered. Participants can claim CME credits and complete a personal development activity using the My L3 Plan tool. And for more info, you can scan the QR code that is up on the screen right now. This activity, while it hasn't been formally reviewed by the CFPC or Royal College, it is still eligible for non-certified credit, and Main Pro participants may also earn additional certified credits by completing a linking learning exercise. All right, with that, let's move on to introduce Dr. Ma. He is a hepatologist, professor of medicine at the University of Alberta, and a good colleague and friend. Mang joined the Division of Gastroenterology in 1995, and he's been an active member since. He's known for his outstanding teaching. He's received the Excellent in Humanism Award from the Faculty of Medicine and Dentistry, the Distinguished Educator Award from the Alberta Society of Gastroenterology, the Canadian Association for the Study of the Liver Education Excellence Award, and the Richard Fedoruk Memorial Award in Professionalism. Mang has one of the busiest hepatology practices around. He focuses on the medical management of patients with fatty liver disease, as well as hepatitis B and liver transplant. And he's got a grant from the Institute of Health Economics to really dig into how clinical service can be improved for urban and non-urban liver patients. And he has helped to establish the first provincial management pathway for metabolic associated steatotic liver disease patients. So without further ado, I'll hand it over to Dr. Ma, who can take us through part 2 of his presentation. Thanks, Mang.
Thank you for joining us, and I'm delighted to be here to continue the part 2 of this presentation series. And so for this talk, I have no conflict of interest to declare, but in this talk, I do discuss treatment that have not received approval for the indication of MASLD or for anti-obesity.
Mang, you still need to share your slides, I think.
Oh, hang on. I thought I've shared already.
Sorry.
For some reason, it disappeared.
Do you see the green arrow? Yeah, great.
Okay. Is that
Awesome.
good?
Yeah, you're on the objective slide.
Okay. So this is a continuation of the series on steatotic liver disease, and I'm focusing on assessment to management in the primary care setting. And so you can use some of the information to help managing your patient. So this is just a review of last week, and steatotic liver disease is actually very common. 1 out of 4 or 5 adults would have fatty liver disease. 1 out of 20 would have steatohepatitis that can progress to cirrhosis. In fact, there's a concern 1 out of 100 person might have cirrhosis related to metabolic associated steatotic liver disease. What is really concerning that even when someone has early cirrhosis, it would be very hard just from routine clinical information, whether symptoms, liver tests, ultrasound, and you will not be able to tell. And the important thing is really to realize that if someone just has obesity or overweight, and obviously they do have a slightly higher mortality than the average adult. Once they have obesity with fatty liver, this creates a generalized oxidative stress in the body that's really increased all-cause mortality, whether related to heart disease, cancer risk, or diabetes. And once they have steatohepatitis, and they have the highest mortality, and that is due to the additional of adverse liver outcome. So obviously, in order to help to identify the right patients to be seen and for treatment, we really need to have a very simple primary care pathway in order to really help all clinicians to identify the right patient to be seen. So in fact, actually dated back to 2015, and we had this idea to really to find a pathway to guide identification of patients that would benefit from specialty care. We did not get any funding until 2017, and only until 2022 before we get endorsement from Alberta Health to implement this pathway. So we want the pathway to be easy to use and follow, allow monitoring of MASLD yearly. The goal is really allow early diagnosis of MASH and particular those with fibrosis, and identify the right patient to be referred to either endocrinologist or hepatologist. So we also want this pathway that can be used by both urban and non-urban primary care physicians. So this pathway should be very inexpensive. And more important is really provide opportunities in trying to change the natural history of the disease, perhaps prevent the development of MASH to cirrhosis, improving obesity and metabolic syndrome, and improving overall health, maybe even decrease cancer risk. We do know medical treatments are on the horizon at that time, and we know that, in fact, they are here already, and there will be more targeted treatment available soon. This become what we call Alberta First Fit for First pathway. So the diagnosis of MASLD really requires either a liver biopsy, which we don't want to do. If without a liver biopsy is really a diagnosis one would have to make, and after ruling out all other liver diseases. So this is a very unfortunate thing we have to do, although majority of abnormal ALT would be due to fatty liver. So after you make the diagnosis, the next step would be risk stratification, and we do that by using a nurse, and the nurse will organize or the primary care physician will organize the Fit for First test, If the FIB-4 is less than 1.3, this is a very good predictor of good negative predictive value of no significant hepatic fibrosis. And essentially, unlikely they will have stage 2 liver fibrosis on biopsy. And if the FIB-4 is greater than 1.3, they get what we call vibration control transient elastography. And most people know that as FibroScan. And a reading of F2 or below unlikely would have a measurement of greater than 8 kilopascal. And if someone has a reading of 10 kilopascal and there's a potential F3 fibrosis, they would get formal assessment. In between, we are not very good at separating different stages. And we, in the interest of seeing the right patient and interest of decreasing wait time, we actually get the nurse to repeat the FibroScan either in 6 months or in a year to make sure this number is really greater than 10 or less than 8. When the number is greater than 14, there's a concern about early cirrhosis. So the guideline for evaluation of MASLD is really based on history, rule out viral hepatitis. If they still have persistently abnormal liver enzymes, they really would have to have a panel of blood tests to rule out common liver diseases. And unfortunately, this is what we have to follow guidelines. But as most of you know, and most of the abnormal ALT would be due to fatty liver. But currently, the guideline still requires to do this panel of blood tests in order to really certain that we are not dealing with, for instance, viral disease, celiac disease, and autoimmune liver disease, things like that. So the provincial pathway and for the whole province is very similar, except in Calgary. Calgary is slightly different because they started using ultrasound sheet wave elastography, and they do not want to switch to FibroScan. And in Calgary, they continue using ultrasound sheet wave elastography instead of FibroScan. So when you suspect NAFLD, and if the ALT is persistently abnormal, then you want to rule out all the common liver diseases. And you want to make sure medication and lifestyle, you would have a good review. And sometimes abnormal ALT could be due to medication and alcohol use. And once you're really certain nothing else contribute to the abnormal ALT, you're very certain that you are dealing with fatty liver disease. And then you order FIB-4. If the FIB-4 is less than 1.3, it's a low risk of significant fibrosis. And the patient do not need to have a FibroScan or be seen by specialists. If for whatever reason FibroScan cannot be done, or the FIB-4 is greater than 1.3, then they will formally get an assessment and with the nurse first. And if the nurse determined that the elastography is greater than potential would indicate the patient might have F2 to F3 fibrosis, then they would be formally seen by hepatologists. So this is the provincial pathway. So even with the provincial pathway, there's still about 30% with FIB-4 greater than 1.3, or FibroScan cannot be done. And so we save 70% of patients from needing to be referred, but we still would have to see about 30% of the patient that would have steatotic liver disease. So to manage patient with MASLD, and for that same reason, obesity, really require a multidisciplinary approach. And the primary care physician is really the quarterback And the hepatologists, endocrinologists, or bariatric surgeons really supporting the primary care physician in managing those patients with significant steatotic liver disease or obesity. And there are nurses involved in getting FibroScan done or monitoring. Support group is very useful. And in clinical trial, and we do a lot of activity training. And that's actually would encourage patients to stick to the activity routine. And the government policy is important. The Fit for First pathway is the first in Canada. And in fact, you can just order Fit for without really have to do your own calculation. And there's a lot of patients with obesity or steatotic liver disease has anxiety, depression, and psychologists, psychiatrists might have roles to play. And obviously, at this time, there's a role for clinical research, and that would allow a lot of patients with advanced fibrosis that they might be able to get new treatment. And at this time, we don't have to wait for them to get formal approval to be used in the routine treatment. So this is essentially a summary of what we're going to talk about. So the primary care physician really has the role of case identification using the MASLD pathway, which is essentially step 1, Fit for, and then followed by FibroScan. And the monitoring of simple fatty liver would be using this MASLD pathway, and it would be in the domain of primary care physician. And the primary care physician really would help a lot to working with allied health dietitians and nurses to address diet, lifestyle, and exercise, and optimize metabolic treatment. And once they have MASH fibrosis, really that potentially get a lot more complicated. And currently, we do have some treatment already, although they're not specifically for MASH fibrosis, but they definitely will contribute to the management. And hopefully we can prevent cirrhosis and cirrhotic complications like liver failure or liver cancer. So I'm going to talk a little bit about lifestyle modification, diet, and activity. Diet is very complicated. And in fact, most people don't realize diet is more than just what you consume, protein, carbohydrates, and different things, fat. So I'm just going to talk about Mediterranean diet, which is a diet full of antioxidants and full very high in polyunsaturated fatty acid. And hopefully with the diet is really not ultra processed, and it will be high in fibers also. What essentially this diet will create decrease oxidative stress, decrease inflammation environment, improve immune function, improve insulin sensitivity, and decrease metabolic syndrome. And as you can see, the diet is more than just caloric content and how much protein, how much fat, how much carbohydrate. It does many things, changing the cytokine and hormones in our body. The diet, because of the unprocessing, the fibers, the other things in it, it alters the microbiome. The microbiome, in essence, will change, improve the gut dysbiosis and the balance between good and bad bacteria, and improve the gut leakiness. This in turn will improve the hormones and cytokines in the body. So a diet is very complicated. And in fact, the reason why we recommend Mediterranean diet because of this anti-inflammation, anti-metabolic stress property, and potential benefit in microbiome diversity. So, and this would be something we recommend to the patient instead of any specific diet that might be hard to maintain over the long run. So I'm actually a fan of intermittent fasting. And so intermittent fasting in a way is try to change your body metabolic system in a way very similar to exercise. And in essence, you want to turn on this metabolic switch that allow your body to adjust to energy use and energy adaptation, depletion and energy repletion. And this kind of ketogenesis to glucose switch is very important, really, to improve long-term adaptation to obtain a metabolic system that is really increased insulin sensitivity, improve your lipid metabolism, in healthy gut microbiota, and reduce fat, reduce inflammation, reduce blood pressure. In essence, is really what we know that in a lot of culture with longevity, they really have this metabolic profile very similar to intermittent fasting. And but there's an abstract presented in American Heart Association and last year, and essentially using retrospective data from Enhance and pretty good size study with 20,000 participants. So what they essentially said, intermittent fasting, which is another form of time-restricted eating. So if someone follow an 8-hour time-restricted eating schedule and had a 91% high risk of death from cardiovascular disease. So I have not seen the the actual paper, but I think there's a lot of potential confounding reason why this high risk of death from cardiovascular disease might happen. So, but in a lot of observation studies, intermittent fasting is actually potentially very good for the metabolic system. So the story is still ongoing, whether that's something we can continue to recommend to a patient. So the next thing I want to talk about aerobic exercise and weight loss in adult. So I'm concentrating on a systematic review and meta-analysis. So look at all the studies. So they actually classify intensity of aerobic exercise program into light, moderate means 3 to 6 mats, and get your heart rate to 55% to 70% maximum heart rate, or vigorous and 6 to 9 mats, or heart rate 70% to 90% maximum heart rate. And a program moderate to vigorous is essentially exercise involving both moderate to vigorous. So just to give you some idea, 1 mat equivalent to sitting quietly, and that would be 1 kilocalorie per kilo per hour. And brushing your teeth would be 2. Walking slowly would be 3 mats. And swimming leisurely would be 5. Rapid walking, as you can see, if you can get your breathing heart rate up, then that would be 6. And that's what I recommend to patients, is really a rapid walking. If you want to be intense, then you get patient run up the stairs, and that would be potentially up to 15 mats. So what is important in that, in what I want to point out to you is really the longer you exercise, and with moderate exercise intensity, the longer you exercise, the better this is actually probably wrong, it should be kilogram. And so the better the weight improvement would be. However, weight improvement is just only one thing. More important is how much body fat you can change. And if you look at body fat, moderate exercise intensity really you require 150 minutes per week in order to achieve this degree of improving body fat. So it doesn't matter what you do, and at least 150 minutes would be required to really achieve the best outcome in improving body fat percentage. So their conclusion is any activity would be useful, but any meaningful reduction in visceral adipose tissue will require exceeding 150 minutes per week at moderate intensity or greater activity level in order to do that. So, and there's some people, this is also another meta-analysis using high intensity interval training and compared to continuous training. Again, high intensity interval training is very similar to continuous moderate intensity training. And but the benefit is time saving. You don't have to find as much time 5 times a week to do the activity. And a lot of high intensity interval training can be quite enjoyable things. You can do a bike, spin bike, or running, quick running, or something more enjoyable like oh, high intensity dancing and things like that. So why is weight loss beneficial? So everything is about visceral adipose tissue. When you have a lot of those, and you have much increased risk in fatty liver and the risk of steatohepatitis and fibrosis. If you can make this visceral adipose tissue smaller, you reduce fat in the liver and fibrosis. A 10% weight loss can be equivalent to 30% adipose tissue loss. And with that, you improve insulin sensitivity, you decrease blood insulin level, improve blood glucose, improve marker for thrombosis, and decrease inflammation. And in essence, you can also improve endothelial function that might have benefit in improving hypertension and preventing heart attack. So weight improvement and MASLD, and so it all depends on whether you are the one that see benefit in everything we do or don't see benefit in anything we do. So a weight loss of 5% can improve 10% of the people might have some improvement in the fatty inflammation. And there might be some people with fibrosis regression also. And so even a little bit weight loss is important. And if they can improve weight by 5 to 7%, again, there's 65% will have some steatosis improvement. If they can improve the weight by 7 to 10%, as you can see, is really now you start having more fibrosis regression. And if you can improve your weight by more than 10%, a majority would have some degree of fibrosis improvement, and 100% of the patient will have steatosis improvement. Unfortunately, very few people are able to maintain over 7% weight improvement. So if you talk about over 7% weight improvement after 1 year of lifestyle change, only about 20% actually can maintain that. Majority cannot. So that's the challenge. But almost someone that think, so even with 20% can do that, that's still a beneficial. That means 1 out of 5 of your patient can do it on their own without actually needing any medication. So it's something I still encourage people to do. So the chance of lifestyle modification alone, and so just using diet and activity is not hard to improve weight by 5 to 10%. But unfortunately, it is difficult to start and maintain lifestyle changes. We all have competing interests because of how busy we can finding the time and finding the time to prepare a meal that would be good for our physiological system. And the second part is your body is really do adaptation. As weight loss occur, the body actually makes it difficult to continue to lose this weight because of adaptation changes. And in fact, a lot of time, the body start to regain weight. So this adaptation physiology is really is our body way to make sure we don't lose too much weight. But at the same time, make it difficult for us to maintain this weight improvement. And meta-analysis show 50 to 80% of lost weight is regained within 3 to 5 years. So that's the challenge of lifestyle modification alone. However, some people can do it and can do it successfully. And for that reason, we should keep encouraging everyone to do it. So obviously, obesity and MASLD, they go together. So, so how we deal with MASLD is the same as how we everyone else is deal with obesity. So, and if someone has simple MASLD, and obviously lifestyle change is the first thing we recommend. However, if lifestyle change cannot be done in an easy way for them, and because of too much weight, it's very hard for them to do activity, or they have some other issue that they cannot maintain activity, then we might potentially add medication. Once they have managed with fibrosis, it's very important to emphasize the lifestyle change and start thinking about adding medication. And the use of medication is actually quite important if someone already has weight-related complications. So there are quite a few anti-obesity medication that potentially can be used in treating MASLD. And you have the combination of bupropion with naltrexone. This is Contrave, and it works on the hypothalamus to decrease eating. And you have the GLP-1, which we have liraglutide, semaglutide, or tirzepatide, and they work on the hypothalamus brain part, and to really help to improve, decrease eating, and the decreased gastric emptying is also decrease the sensation that you want to eat more. And there are other medication things that you can use, and those are not commonly used anymore. And so I won't go into detail on those. But there are many more specific trial medications that actually in phase 3 with intention to target steatotic liver disease and not directly related to weight loss. And lanifibranor and is already approved by FDA to be used in PBC, and is a pan-PPAR medication. And resmetirom is the thyroid hormone receptor beta agonist. It's also approved by FDA specifically for treating MASLD. And those are medications that seem to be quite promising in the phase 2, phase 3 trial. And in fact, the FGF21 class is quite interesting. And I do want to go over a little bit on the FGF21 later. So efficacy of current FDA-approved obesity therapy, these are not direct comparison control trial. So if you look at bariatric surgery, you can think about 25% weight improvement. When you talk about semaglutide, you can think about 15 to 20% weight improvement. And if you talk about this combination of phentermine and with topiramate, and you can talk about 10 to 15%. liraglutide is about 10%. If you talk about blocking fat digestion, it's less than 10%, and contrast is also less than 10%. So as you can see, the GLP-1 type of medication and bariatric surgery will give you the best weight improvement. So the GLP-1 agonist has many different effects. Not only it's changed gluconeogenesis in the liver, decreasing hepatic fat, and it affects gastric emptying and gastrointestinal motility. That's what causes people have gastric retention. And when your stomach is full all the time, you really don't want to eat. And interact with the hypothalamus, really decrease food intake and decreasing reward behavior. And this is what the anti-craving effect is. And it also improves insulin sensitivity and glucose uptake by the muscle. It also improves your pancreas function. And for that reason, and GLP-1 is a potential medication that would be very effective in MASLD treatment. And in one of the early trial, and the paper hasn't been published yet, it's presented in November last year liver meeting. And it's called ASCENT trial using semaglutide. And the dose is much higher than Ozempic. The dose is 2.4 milligram. And when you look at resolution of steatohepatitis without worsening of liver fibrosis, 62% of the patient would have improvement of steatohepatitis. However, the improvement of fibrosis is much more modest at 37% compared to 22% in placebo. As you can see in clinical trial, the placebo group always can do better in routine clinical setting. Partially, we have the trial nurse telling them every time they come into the clinic for visit, they have to maintain their activity. They have to pay attention to their diet and their weight change. So this feedback is potentially very important. So the secondary endpoint in this study is what I want to concentrate is steatohepatitis with improvement in liver fibrosis. So improving inflammation alone is not as important as improving both. So again, you see 32, almost 33%, one-third of the patient would have improvement in both inflammation and liver fibrosis. And so the mean body weight change is about 10% on semaglutide 2.4 milligram compared to placebo. It's only 2% weight change. And there's some improvement in quality of life, obviously, when you do improve the weight by 10%. So this is the original paper on tirzepatide in treatment of diabetes. In this diabetic study, what is important is you see this dose-dependent improvement of weight up to 20% on the high dose of tirzepatide 15 milligram. As you can see that on the small dose one, there's some leveling of weight improvement. But in the high dose, you can see the continuation of weight improvement until up to 72 weeks. So, and for that reason, this medication is also being studied in the treatment of steatotic liver disease. So again, this is presented in the recent liver meeting and also published in New England Journal of Medicine, looking at tirzepatide in the treatment with MASH. As you can see, the high dose of tirzepatide, and it can 62% of the participants would have resolution of the inflammation related to fatty infiltration without worsening of fibrosis. And when you look at fibrosis improvement and without worsening of inflammation, and it's interestingly, the dose is not as important. And the low dose and high dose would give you very similar. Half the participants will improve fibrosis, and it doesn't matter whether they are on the highest dose or the smaller dose. So this medication, resmetirom, I don't know how they come up with all those names, and it's a thyroid hormone beta receptor agonist. Thyroid hormone actually is alpha and beta, and the beta is really what essentially targeting the metabolic pathway involved in hepatic lipid metabolism and inflammation. As you can see in this Maestro NASH study, and 30% of the patient would have resolution of inflammation, and 26% would have improvement of fibrosis by at least one stage. And this medication has already been approved by FDA to be used in treatment of steatohepatitis. So what I want to talk about is this studies of using FGF21, and the medication is called efruxifermin, and it's a FGF21, which is actually a hormone in our body, and this is a synthetic hormone, and it can potentially improve liver fibrosis and fatty liver, and through intracellular pathway that will reduce stress in the liver cells and prevent liver from damage. And it has potential benefit in decreasing body weight, improve insulin sensitivity. In fact, in a clinical trial, hypoglycemia is one of the potential adverse event effect with the medication. And it can improve whole body metabolism. So in this study, and looking at 24 weeks to 96 weeks, as you can see, and a lot of people actually can have more than one stage improvement of fibrosis, 75%, and with greater than one stage improvement in fibrosis without worsening of inflammation. And now, so when you're looking at conventional histopathology, you cannot really look at the density of fibrosis. So they're also using digital pathology, which is essentially looking at how dense the fibrosis is. And there's actually better improvement. So although the liver might look very similar, but the density of collagen of fibrous tissue is actually less. However, as you can see, when they start looking at intention to treat, and the benefit is not as much. That means there's a lot of patients drop out from the trial for whatever reason. So the benefits is really not as impressive when they look at all comers. And once you take away people who drop out, then looking at intention to treat analysis, it's only about 50% versus 75%. What is interesting about this medication is it potentially can reverse early cirrhosis. So in this study, they look at compensated MASH cirrhosis with no clinical significant portal hypertension. And interestingly, they demonstrate in this small study that a third of the patient might potentially improve from early cirrhosis to lower stages of fibrosis. So whether they can, in a bigger study, to reproduce the result or not, I'm not completely certain. A small study sometimes can be biased, and liver biopsy sometimes can be deceptive. This is not presented in any conference. This is a press release by the pharmaceutical company. So it'll be interesting to see the actual presentation whether they actually can do that or not. So bariatric surgery, and there are different types of bariatric procedures, and obviously is patients with morbid obesity or complications related to obesity, and they might be a potential candidate for bariatric procedures. And adjustable gastric banding means making your stomach smaller, and it has potential to improve weight by about 15%. The sleeve gastrectomy, also making your stomach smaller, and is slightly better than the gastric banding, about 20%. If we do a Roux-en-Y gastric bypass, it's about 20 to 25%. If you do a very complicated diversional duodenal switch procedure, and this benefit could be up to 30 to about 30% weight improvement. Now, obviously, as you get procedure more complicated, there's potential nutrition consequence also. And although weight might be improved, other nutrient deficiency might start becoming an issue. So as you can expect with weight improvement, the bariatric procedure definitely can decrease adverse liver outcome compared to non-surgical outcomes. In this study just recently published in Nature Medicine, they match patients with medical therapy versus people with bariatric procedures. And the bariatric procedure does improve liver outcomes. And obviously, how to identify the patient that would best benefit from bariatric surgery is something remain to be seen. So this is the long-term challenge in managing MASLD or obesity. So whatever you do, you can improve weight, but weight maintenance is a challenge. If you're using anti-obesity drugs medication, so whether it is semaglutide or any GLP-1, the moment you stop the GLP-1, the weight will return. So you really have to maintain this anti-obesity medication in order to provide this maintenance. Even when you maintain that, there's still some regain of weight. The same with bariatric surgery also. So the challenge is really, so you improve the weight, and what can you do to maintain the weight if you don't use medication? So that obviously all those long-term consequences, if someone has to take something for more than 20 years, how is that going to affect their body physiology and nutrition issues? Just to give you some idea, let's just say if you're using GLP-1, and so there's a lot of concern of when you have stasis in the stomach because of gastric emptying issue, and you have going to have bacterial overgrowth. This bacterial overgrowth is going to this bacterial overgrowth is actually will get worse when they start getting a lot of reflux, needing PPI to treat the reflux. Now you don't have the stomach acid, you're going to increase the bacterial overgrowth. And this bacterial overgrowth is going to affect your whole gut function and potentially micronutrient absorption. And so those are things remain to be seen, what the long-term consequence of changing our GI motility and gut physiology. So I'm going to go into this paper, and this paper generated a lot of discussion in the press, and it published in Nature Medicine. And we said what the title is interesting, mapping the effectiveness and risk of GLP-1 receptor antagonists. So in essence, they classified them into blood and blood-forming organs benefit, circulatory benefit, digestive system, endocrine, GU, infectious and parasitic disease, mental, MSK, cancer risk, nervous system, respiratory, and symptoms. However, a lot of those really could be just related to improving weight and it means improving health. So there are a lot of cardiovascular benefit. And as I mentioned to you, improving weight, improving visceral adipose tissue can really improve your endothelial function, decrease thrombotic risk. And as you can see, they can see that also. And obviously, improving your weight would improve heart failure, pulmonary hypertension, and post-thrombotic consequence, thromboembolic events, and all those things, ischemic heart disease. And the digestive system is less liver failure. And interestingly, it might have potential improve inflammatory bowel disease. And infectious complications, if you're diabetic or obese, then risk of sepsis definitely would increase. By improving weight, that would improve this also. And the anti-craving effect is potential benefit, alcohol use disorder, opioid use disorder, and interestingly, might help schizophrenia, suicidal ideation. So there are a lot of benefit they listed. And in cancer risk, it does decrease liver cancer also. So the potential consequence is hypertension and gastroesophageal reflux disease, diverticulosis and diverticulitis, and increased risk of gastroenteritis and gastroparesis, and increased risk of kidney disease and kidney stone. And it potentially affect the arthritis, osteoarthritis, tendonitis, bone pain, and sleep disturbance, headaches, and nausea and vomiting, very common on GLP-1 type of medication. And with hypertension, syncope could be an issue also. So I have gone over a lot, but the take-home message is it's very common. And unfortunately, routine clinical information doesn't help you to determine how severe the steatotic liver disease is. And for that reason, our primary care pathway is very important. Allow monitoring of the MASLD yearly, early diagnosis of MASH with potential fibrosis, and identify the right patient to be referred for further assessment and management. And our hope is really finding the opportunities in changing the natural history of MASLD and preventing cirrhosis, helping obesity and metabolic syndrome, perhaps overall health, and decrease cancer risk. And the treatments are here. And if you find the patient that need to be treated, we should start treating them with, at this time, GLP-1 is available, who can potentially do that. And there are new medication on the horizon. So if GLP-1 doesn't work, then we could use other medication also. So this is the fit for first pathway. So this is how we need to work together in preventing the progression to this end-stage liver disease, and hopefully we block the progression to cirrhosis, and from cirrhosis to liver failure and liver cancer. So this is the most important thing and it's really not only improve the metabolic physiology by decreasing the visceral adipose tissues, and that would help with decreasing liver fibrosis and improve overall mortality. So that's really what we need to do for both obesity and steatotic liver disease is really improving this visceral adipose tissue. So this is just to give you what in the next few years we're going to do is, and with our diet and lifestyle change, they should be able to improve weight at least by 3 to 5%. And if lifestyle cannot work, then we can start thinking about anti-obesity medication. And if they start developing steatotic liver disease with fibrosis, now we can potentially add more target MASH treatment medication. And obviously, gastric bariatric surgery would be the last option that we can still use if everything else would not help the patient. So the pathway to identify patient at risk of MASH with fibrosis is important to really target those people. And hopefully we can, as more options available, we can tailor approach to maximize benefits and reduce potential long-term adverse effects, and not only improve liver outcome, but overall health and overall mortality. So I'm going to stop here.
Thank you, Mang, for that talk. And we do have just a few minutes left for questions. So I just want to remind you, as Mang's answering some questions around just filling out the evaluation, and you can just scan that. That'll take you just about 3 minutes to do. So Mang, let's try and do short answers if we can for these so we can get through them. Diagnostic imaging facilities are offering elastography. What role does it play in the pathway, or should primary care be ordering elastography?
So yeah, so unfortunately, the shear wave elastography is operator dependent. So, and FibroScan is less operator dependent. And for that reason, you can get funny results from shear wave elastography. And we are working with the city radiologists to really improve consistency in elastography done by ultrasound.
Okay, yeah, excellent. And same question about relying on elastography or just refer anyone with FIB4 greater than 1.3.
So just refer for FibroScan, and it's cheaper than ultrasound elastography anyway.
Okay. What are the reasons for ordering immunoglobulins, the IgG, IgM, IgA?
Yeah, so it's part of the ruling out autoimmune disease. So that immunoglobulin is helpful. IgG, if it's high, if it's very high, it might suggest autoimmune disease. If it's mild to moderate high, it might suggest significant fibrosis. IgA elevation is common in fatty liver or alcohol liver disease, and IgM is elevated in PBC patient. So we do the immunoglobulin profile.
Okay. And what do you tell your MASLD patients about alcohol consumption? Is light drinking okay or no alcohol?
We actually said the occasional celebration is okay, and we're really using the current Canadian guideline, in essence, said no safe limit in alcohol use. So a couple of drinks a week probably would be fine. Another question?
I think we lost Bonita. So sorry, the question that's being asked again is, should GP order elastography? It looks like somebody missed the previous answer.
Yeah, so if the FIB4 is elevated, just send in the refer to the provision pathway. You don't need to order ultrasound elastography.
Super. And one last question, are certain groups of patients more prone to MASLD, for example, the indigenous group or the South Asians?
It's a little bit complicated in the sense that that not only the dietary change in certain group, and so it's yes and no. It's a little bit more complicated. And for instance, for indigenous, their lifestyle change is completely different. And when you look at 100 years ago, indigenous lifestyle is very different from indigenous lifestyle now. So, and there's also other reasons that complicate things also in indigenous population. For South Asian population, and when they move to North America, and the diet changes is quite drastic. Not only let's just say vegetarian diet. Vegetarian diet is not particularly completely healthy. So this vegetarian diet would get worse when they move from their native country to North America.
Okay. Sorry, my internet just dropped there, but I know we're over time. I think there was just one last question, Mang, if you could answer it really
Yeah.
short. Do we see similar weight loss issues if patients stop the new medications? So do they regain the weight that they've lost?
Well, in essence, over time, they pretty much regain all the weight. So that's the challenge of the adaptive physiology. And when you eat less, your body adapts. And when you remove medication that suppress your appetite, your body physiology is really getting used to conserving energy. So when you start eating more, people can regain their weight quite fast. And sometimes their weight might even be higher than previously before they were tried on the anti-obesity medication. So everyone's a little bit different. So the issues we hope by improving the weight, it's much easier for them to improve the activity. So when your weight is high, activity is an issue, and injury is an issue also. So if you walk around carrying 25 pounds of sandbag, and the kind of injury to your musculoskeletal system is quite a bit over time.
Okay, thank you, Mang. As always, such an excellent presentation. And thank you everybody for attending. I would just end by asking you to reflect on what you've learned today and how you can implement it in your own practice. And you would have seen some slides up around making a personal development plan using the MASLD plan. And there's a QR code there that you can use. It's a free online tool. It can be used to support the 3 activities and action plans required by the CPSA, Physician Practice Improvement Program, and you can also earn CME credits with it by completing the following cycles: the practice-driven quality improvement, the personal development, or the standards of practice quality improvement activity. And then I will just end with what's coming up next. So we've got a 3-part webinar series presented by Dr. Darren Lau and Dr. Donna Manka, and February 11th from sugar highs to fat fries, and then March 4th, the diabetes dilemmas. So thank you everybody for attending. Thank you, Dr. Ma, and thank you, Lifelong Learning team, for all that you do as well. Have a wonderful Tuesday, everyone, and we'll see you on the next session.